In this video, we will demonstrate MRI TRUS fusion guided focal HIFU therapy of prostate cancer using the device Focal One. The robotic platform offers image planning and fusion modalities, followed by focal therapy and monitoring using contrast-enhanced ultrasound. Whole gland treatments can lead to patient-reported side effects. Active surveillance of expected indolent cancers harbours a substantial risk of disease progression. Multiparametric MRI and targeted fusion biopsies allow for an improved tumour localization. This information can be used to guide focal ablation. Consequently, there is growing interest in focal therapies to preserve genitourinary function despite active cancer treatment. We report on 24 treated patients with a 12-month follow-up. All patients were enrolled in prospective clinical trials and had histologically proven localized low or intermediate risk prostate cancer. We present the workflow of focal HIFU therapy in a step-by-step manner using the example of a 74-year-old man who presented with prostate cancer in the left apex. MRI contours of the prostate are delineated by the surgeon in the transversal T2 sequence. At least 3 contours and the determination of apex and bladder neck are necessary before an automatic interpolation of the software. After that, the yellow region of interest is contoured, and the MRI 3D model is ready for the image fusion. The combined imaging and therapy probe is placed on a robotic platform. Piezoelectric elements in the spherical transducer of the probe enable the generation of 3 MHz acoustic waves for heat ablation. Cooled coupling liquid flows continuously through the latex balloon to protect the rectal wall and adjacent structures. Using a temperature detector, we are able to maintain a constant temperature. A light barrier immediately detects patient movement and automatically stops the treatment during the ablation. A restart with replanning of the lesion might be necessary in such cases. 2 screens allow the user to monitor and adjust the ablation. The amount of energy delivered through the probe depends on the treatment mode. The patient is placed on gel pads in the right lateral decubitus position. All procedures are performed with the patient under general anesthesia and using an indwelling catheter. The basal and apical borders of the prostate are manually set to allow automatic ultrasound image acquisition thereafter. The boundaries of the prostate are marked to allow the calculation of the prostate volume. Again, the contouring is started manually before an automatic software-based interpolation completes the 3D model. The measurement of the apex basis and the transversal distance compared with 3D MRI model enables us to estimate the fusion quality. Elastic image fusion is used as the basis for focal treatment. During this process, the prostate MRI volume undergoes a 3D deformation to fit the prostate TRUS volume as closely as possible. After the fusion, the yellow region of interest is displayed in the TRUS volume. If the elastic fusion clearly does not match, it should be revised. The exact fusion is the mainstay for a successful targeted ablation. Since 2016, a further feature is also available. In addition to fusion with MRI images, it is also possible to fuse with 3D images from fusion biopsy platforms such as Artemis and others. This enables us to visualize the positive cause within the 3D volume for the focal HIFU treatment. It remains to be shown whether this additional fusion option with the live TRUS volume helps to identify the treatment area more precisely. One needs to take into account diagnostic and fusion uncertainty when planning the treatment area. The safety distances around the lesion are measured. In the treatment module, the safety margin can be displayed in detail. The rectal wall is automatically detected, and the minimum distance to the first treatment point is 3 mm. The blue contour of the treatment area is drawn by the user, and the orange lines limit the firing zone. The treatment starts at the most anterior point set by the user and progresses in a posterior direction. The probe automatically covers the whole area. The turquoise blue points are automatically set by the software. Each subshot leads to a necrosis of an oval area of around 5 mm in size. Additional shots allow the lesions to be stacked. The movement of the probe relative to the rectal wall and the firing parameter are controlled by the software. The whole procedure needs close monitoring by the surgeon. Adjustment of the localization of shots is possible at any time during the procedure and is often necessary. As a result of the ablation, the gland deforms, and the surgeon needs to be sure that the planned zone still corresponds to the cancer area. But breaks taken for readjustment should not be too long, as the effect of heat loss might lead to insufficient tumor ablation. Another effect during the ablation are cavitations. They show up as white areas on the ultrasound and do not affect the efficiency of the ablation. But if visualization of the contours through cavitation is no longer possible, the treatment must be paused to avoid high temperature damage to the rectal wall with consequent fistula. Ultrasound contrast agent is administered to enable initial rough therapy monitoring. The onset of the contrast agent can be visualized and the TRUS scan started appropriately. If hypersignal areas indicate vascularization within the ablation area, the user can compare this with the previously planned region of interest and thus define repeated treatment of the area. 27 lesions were treated. The median treatment duration was 61 minutes, including planning and post-HIFU-therapy control. The median volume of the HIFU-treated lesion was 6.8 milliliters. 20 patients received a control biopsy within 12 months of the ablation. Depending on the cancer-free rate definition, the cancer-free rate across all patients varied between 50% and 95%. This figure demonstrates the change in PSA level from baseline to 12 months after treatment. A PSA decrease of 50% or more from baseline was achieved in 11 patients. There were only a few complications according to the Clavian-Dindo classification. One suprapubic catheter had to be inserted.